Good evening and welcome to the OBI Public Talk Series. My name is Tom Mickelson. I'm the President and Scientific Director of the Ontario Brain Institute, also known as OBI. We're a provincially funded non-for-profit that accelerates discovery and innovation, benefiting both patients and the economy. We champion a collaborative team science approach, promoting brain research, commercialization, and care by connecting researchers, industry, patients, and advocates, all to improve the lives of those living with brain disorders. The purpose of the OBI Public Talk series is to shed light on complex issues, to fight stigma with knowledge, stimulate our brains, and challenge ourselves to continue learning. Major depression continues to affect close to 2 million Canadians annually, and about 10% of Canadians who are 15 years or older have experienced depression at some time in their lives. Given the ubiquitous nature of depression and mental illness, we must continue to bring mental health and well-being to the forefront in the public conversation so that everyone feels comfortable speaking about these challenges. And a crucial step is encouraging individuals to seek the appropriate help by better understanding their options so they can make informed decisions together with their healthcare providers and loved ones. We're proud to be partners with TVO, and tonight's talk is being live streamed on tvo.org. A video of the talk will be made available on our website later this week. And during the talks, you can put forward your questions by direct messaging us on Twitter @OntarioBrain, or by sending us an email, and the details will be on the screen soon. Before we dive into tonight's conversation, we'd like to share with you a few thoughts from the Honourable Michael Tobolo, the Associate Minister of Mental Health and Addiction from the Government of Ontario. Thank you.
Hello, my name is Michael Tobolo, the Province of Ontario's very first Associate Minister of Mental Health and Addictions. It gives me great pleasure to have this opportunity to address you all here today. While we can't gather in person together this year, I want to thank each and every one of you for your ongoing dedication to better understanding and supporting those living with mental health challenges, especially during these difficult times. Without a doubt, the COVID-19 outbreak is almost unprecedented in our province's and our country's history. These are truly extraordinary times. We know that when people are experiencing something new and unfamiliar to them, that can cause many people to experience stress and anxiety, among other mental health challenges. And when it is on the magnitude of this current outbreak, then those stressors can become a lot for a person to manage on their own, even with the support of their family or friends. Since the start of the COVID-19 outbreak, our government has seen thousands of Ontarians reach out for help. And it's been our mission to ensure that Ontarians of all ages who need the extra help are able to access the supports they need when and where they need them. That's why I was pleased to join the Premier just a few weeks ago to announce that our government is taking further action to increase access to mental health and addiction services by providing an additional $14.75 million to better support Ontarians of all ages. This investment is going to be spread across our mental health and addiction system and provide support for people and families in many different ways. This investment includes additional funding to expand virtual and online services being used by thousands of Ontarians, such as internet-based cognitive behavioral therapy for those experiencing heightened anxiety and depression during these difficult times. We're also proud to be funding culturally safe services for Indigenous people in Ontario and community-based services to support both in-person and virtual services for Ontario's children and youth. Finally, funding is also going to help supportive housing providers with outbreak management in congregate living sites, including supportive housing for clients who are living with serious mental health challenges. These investments are all part of our government's larger overall commitment to mental health and addictions. They all fall under the umbrella of our government's Roadmap to Wellness, a plan to build Ontario's mental health and addiction system. Our plan for the system was developed following extensive engagements with experts, grassroots organizations, healthcare providers on the front lines, and first responders, as well as people with lived experience, families, and caregivers. These consultations were necessary to ensure that Ontario can provide a clear path forward to offer people easier access to higher quality care in communities across the province. The new Mental Health and Addiction Centre of Excellence within Ontario Health serves as the foundation on which the Roadmap to Wellness is built. This centre is fulfilling the recommendations made in 2010 by the Select Committee on Mental Health and Addictions, for which Deputy Premier was Vice Chair, and which was established through a motion she presented that was unanimously supported by this legislature. The Mental Health and Addiction Centre of Excellence within Ontario Health is finally providing us with a central point of oversight for mental health and addictions care. It has already begun the important work of standardizing and monitoring the quality and delivery of evidence-based services and clinical care across the province to provide a better and more consistent patient experience. It is also providing support and resources to Ontario health teams as they connect patients to the different types of mental health and addictions care they need and help them navigate the complex system. Our government is committed to ensuring the roadmap is a success, and that's why we're investing $3.8 billion over 10 years to create new services and expand programs. In fact, we have already started to fulfill urgent gaps in care that our system partners have identified through immediate investments. We invested an additional $174 million more in annualized funding for mental health addictions programs in 2019-2020. And we will continue to engage with our system partners, including Indigenous communities and other communities with unique needs, to help guide the effective implementation of this plan. The Roadmap to Wellness moves us in the right direction toward building a comprehensive and connected mental health and addiction system that works for all Ontarians across the lifespan. It is a plan that is client-centered, data-driven, and evidence-based. Most of all, it is a plan that will ensure that all Ontarians are able to access high-quality services and supports where and when they need them. Our government wants to create a mental health and addiction system that works for every person in Ontario. We made a promise to the people of Ontario to address the growing frustration with capacity issues within our mental health and addiction system. Through our investments, we're helping those struggling with mental health and addictions to get the care they need in a way that is better integrated and connected to our healthcare system. And we continue to look at ways we can increase funding to address urgent gaps in care and wait times for mental health and addiction services, create new supports, and expand programs. Supporting people facing mental health and addiction challenges continues to be a top priority for our government, and a priority for me as Associate Minister for Mental Health and Addictions. I will continue working with our partners, including the Ontario Brain Institute, to enhance existing supports while exploring new and innovative services to ensure Ontarians receive the high-quality care they expect and deserve. Once again, thank you for the invitation to speak to all of you today. I look forward to working with you to improve and expand services, find innovative solutions, and improve access to mental health and addiction supports for all Ontarians. Thank you.
Good evening and welcome to our panel dealing with depression. What are the options? Tonight we're going to have four great panelists. I'm going to introduce them briefly, but before I ask them questions, I'm going to ask them about their careers more broadly so I don't have to read long bios. So our four panelists tonight will be Marianne Lewis, Dr. Sydney Kennedy, Dr. Lina Quilty, and Dr. Daniel Bloomberger. So I want to start right away with Marianne. Marianne, you have lived experience. You've lived with depression for a while. I want to first of all tell us a little bit about yourself beyond the depression. Tell us about who you are.
Sure. Yeah. Currently, I am in Teachers College at the University of Ottawa. I just finished my math degree last spring, and I am working towards becoming a math teacher, high school level. Other than that, I live with my parents and my 3 dogs, and I like to bike and read and draw. Yeah, that's about it about me.
Great. So you were diagnosed with depression at a fairly young age, around 16 as a teenager. Tell us a bit about the journey. How did you get diagnosed, and how has it been living with depression?
Well, I was diagnosed at 16, but hindsight being 2020, it's clear that I've actually had it my whole life. I was diagnosed at 16 because I was experiencing something that I now know is called intrusive thoughts. And I was having this recurring thought, I don't want to be here. I don't want to be here. I always thought it meant, I don't want to be at school or at home or wherever I was. But it became clear that it was a little bit more existential than that. So I got my mom to make an appointment with my doctor, and I saw her and I explained to her how I was feeling, all of the symptoms I was feeling, the fatigue, the sadness, like crying for no reason, the anxiety, the panic attacks that I was experiencing. And she was like, all right, so you have clinical depression. And I was like, oh, okay, that makes sense. And she first suggested that I see a psychologist, and she gave me a couple to look at. And she also suggested diet and exercise, which is very important when dealing with depression. But if you can't get out of bed, it is very hard to go to the gym and eat vegetables. So that didn't have much of an effect. And the first psychologist that I saw was a child psychologist. And at the time, I was then 17 and not a child very much. So I didn't see eye to eye with her, and I ended up going to a different psychologist. So after I sort of figured out what I'm dealing with, all of these symptoms, how am I supposed to actually handle it? I started taking medication about a year after my diagnosis, and that was really key for me. I've taken very many different medications over the past decade or so. I'm currently on one that is working. I've had some that have worked in the past and then stopped working. And now I am currently in a good zone where my meds are working. And I see my psychologist that I met, 9-ish years ago. I still see her about once a month. So that's the general start of how things went.
So a mixture of some psychology, some medication. You mentioned sadness. People don't always understand. What's the difference between being sad and being depressed?
Well, the sadness itself isn't much different than the regular sadness somebody would feel, but the difference is really how long you feel it. Like if something bad happens, you might feel sad for a couple of days. But the depression sadness is a sadness that like overwhelms you, and you end up feeling it for a couple weeks that turns into a couple months. And it's the type of sadness that doesn't go away with, watching a comedy show or something that would usually make you happy. It's very much more all-encompassing, if you will.
Yeah, all-consuming. And a lot of us, a lot of people are feeling a lot of emotions with the elephant in a room we have to address, COVID-19. How is that? How's the pandemic affecting you? I know it's affecting a lot of people. How's it affecting someone who is already living with depression?
Well, I'm lucky enough to have been dealing with this for a long time, and I guess that's not really lucky, but I mean, I have it under control, and I'm able to take care of the things that are happening. One of the things that I do when I am not feeling great is I go out to a movie or to the mall or something and go out into the world and do something so I'm not so lost in my thoughts. Couldn't really do that during COVID. So as you can see from this beautiful photo, collage of photos, I decided to throw myself into projects. This is only a small percentage of the number of projects I have overtaken in the last couple of months. Doing things, creative things, large type things that I can just throw myself into to, forget about all of the other sort of thoughts flying around in my head, where I would usually, go out and interact with other humans to get rid of those thoughts. I had to sort of figure out another avenue to do that, for sure.
Great. So we'll come back to some of these issues. I want to bring some of our other panelists in, some tough questions too, not just you. I want to remind the audience that you can ask us questions. We want to incorporate them into our discussion. If you go to Twitter at Ontario Brain, and you can send a DM or a direct message, or if you prefer email, communications@braininstitute.ca. So I want to bring in next Dr. Sydney Kennedy. Maybe we'll start, Dr. Kennedy. Tell us a little bit about yourself and what you do.
So I'm a psychiatrist. I'm originally from Ireland, but I've been in Canada longer than in my life than I've been in Ireland. I'm a clinical researcher, so I've studied depression for more than 3 decades. I've always been interested in the interface between the environment and the stresses that we have to live with, and what are the kind of internal and, if you like, biological mechanisms that go with the internal brain function. And I think we've come a long way in being able to avoid the separation and saying this is a psychological problem or this is a biological problem, because we really understand the interface between the two constructs.
Great. And we hear from patients over and over that, my meds don't work, the therapy doesn't always work. Why is it so hard to treat depression?
Well, I have a slide that might... If I was a respirologist and I told you that your diagnosis was a bad cough, I'm not sure that it would be very helpful in deciding what the best treatment was. So depression, in a way, we have improved beyond the bad cough analogy, but the problem is there's no single depression. There are people that the depression is part of what we call major depressive disorder. They have recurrent episodes of only depression. There are others where the diagnosis might be bipolar disorder, so they're going to have episodes of depression and sometimes episodes of mania or hypomania. There are many different factors. There are some people who have a very strong family history. There are some genetic clues as to what happens in terms of the brain, the genetics, the effect on the brain. There are, of course, life experiences. There are lots of issues of early childhood trauma, major life circumstances. Some people are going to be traumatized more by COVID than others are. I've seen people who it's almost a relief to be taken out of the stresses of the world and be quarantined. I've seen other people where COVID has had a major impact on them. So I think the key issue is that different people have different mechanisms, and they arrive at a similar endpoint in terms of symptoms. So if I can show another slide for a second, I think the point is that we have psychiatrists make a diagnosis of depression by asking questions about how you're feeling, how you're thinking, your energy, your sleep, many of these issues. So here is Kathy on the left and Anthony on the right. And these are two individuals who actually, both by our current diagnostic system, actually have a major depressive episode. They've had these symptoms for weeks to months, and they've become dysfunctional because of them. So you can see that Kathy's weight loss, her difficulty getting enough sleep, thoughts of suicide, low self-esteem are quite different from Anthony's hypersomnia, sleeping 12, 14 hours a night, overeating, gaining weight, having no energy. And the core issue is that Kathy has a really marked low mood. Whereas Anthony says, well, my mood isn't really the issue. The things I do and I used to enjoy, I get absolutely no pleasure in. So we are actually moving forward in some ways beyond the bad cough. And you'll see a very schematized brain here. And what I'm really saying is that we can do functional brain imaging. Most people know about structural imaging with an MRI, but we can actually see the brain at rest and in terms of the brain at work. We can give challenges, and we can see different circuits in the brain that may be over or underactive in relation to different symptoms within depression. There may be the cognitive circuits, it may be the emotion, the sadness, it may be what Anthony has, this lack of interest or pleasure, sometimes called anhedonia. It may be a recurrent ruminative self-blame, for example. So we can see some or all of these, and we can begin to try and tease apart what would be the right treatments for each of these type of depressions.
And how do you distinguish between sort of normal emotions and depression? You know, we don't have a test, we don't have a swab you can stick in your nose and you have depression, yes or no, like COVID. How do we figure that out?
Well, I think there is a continuum. I think Marianne's answer was a very good answer earlier about the difference between sadness and depression. It's a very normal thing to be depressed in a minor way when you get bad news, to be sad, maybe to not be able to sleep. But I think there's a time frame to the bouncing back, if you like. I think the fact that the disorder of depression is very much more complex. It's accompanied by lots of symptoms all at the same time, including a sense that it's not worth living, and a conviction perhaps that you don't deserve to live. Feeling sad at a loss in your life is a healthy and normal reaction. And people who have a depressive disorder can often say, I know the difference between feeling grief when a friend or a colleague or a family member passed away. And that's quite different from going into an episode where there's no obvious reason why I'm in this episode at this time.
Okay. Now, you're a researcher. Depression is very, very costly, one of the leading causes of disability in the world. Do we invest enough in this, in the prevention and the understanding of depression?
Well, I think the answer is a resounding no. We don't invest enough. We've certainly put money into mental health. It was very good to hear the Assistant Minister make a very positive statement about the progress. And I think that Ontario and Canada in general is quite progressive in research in depression. But compared to heart disease, compared to cancer, many other disorders, we do not hit the same level of urgency in terms of getting funding. And of course, we also know that if you look at the cost to the system, whether you look at healthcare, you look at the lost opportunities in terms of workplace, both presenteeism, which is being at work but being very functioning, and also being absent. The cost to any country is actually higher for depression than any other disorder. It often starts early in life, it continues to repeat itself, and so it's really a major and significant burden on our economy.
Great. Thank you. And lots to think about there. You're already generating a bunch of questions from our audience, so we'll come back to some of those points. But I wanted to bring in Dr. Lina Quilty. Dr. Quilty, I'm going to start like the other panelists, ask you to tell us a bit about yourself and what you do.
Great. So I'm a clinical psychologist by training, and I currently work as a senior scientist, as you saw, at the Center for Addiction and Mental Health. And I've been at CAMH now for 15 years, and a central preoccupation of mine during this time has really been how to help folks make decisions about the treatment that is going to be the best fit for them. It is really quite common that there's a lot of trial and error when folks initially reach out for supports, and we know that there are literally hundreds of thousands of Canadians every single year, for example, who are making the decision between medication versus psychotherapy. And right now, there's very little information to help them to make that kind of choice beyond their own personal preferences as well as availability. So being able to be part of the research that will help build that knowledge, build that evidence base, so that folks can make the decisions that are going to be the best for them and help them to get the treatment that's going to be best suited for them, is something that's been a real passion of mine over the last 15 years.
But there's kind of a stereotype. You have depression, you pop a pill, right? Do we know what works better? Does medication work? Does psychotherapy work? Do we have to do both? What should people be looking to?
Well, that is a big question. Certainly, what the research so far suggests is that medication and psychotherapy are approximately equal in their effectiveness, and that the combination of them is, in fact, even more effective. That said, it's not clear whether everyone really does need that combination approach, and whether or not we can be more strategic or targeted in those more intensive approaches. So really, I think there's a lot of important, necessary research to be done on exactly that question.
And a question people often have is they wonder, like, I think I'm depressed. When do I know that I reach out for help? What point do I do that?
And this is so key. One of the biggest barriers, I think, to folks reaching out to psychotherapy, of course, there are many. Time, money, availability are significant. But one of the big questions that comes up, or the big barriers, are the thoughts that, my problem isn't that bad. It'll go away. I kind of know what to do, which leads directly to the question of, well, how bad is bad enough? How long should I wait feeling this way before I reach out for help? And one of the things that I recommend that folks do here is to monitor how you're feeling. Monitor how you're feeling daily if possible, but certainly weekly. And also monitor your substance use if you can. Those two often go together. And see if you're finding that your mood is low for more than half the time, or for as long as 2 weeks. As Marianne really noted, that a lot of our moods fluctuate, and that's expected. That's not something I think that we should try to pathologize or catastrophize about. But if after that period of time you're finding that you're still feeling quite low, it is reasonable at that point to be perhaps consulting with trusted others, exploring your options for supports. If you really think about mental health as being health, you wouldn't tolerate something like a dislocated shoulder for 2 weeks. without, any kind of consultation. By all means, take into account your personal circumstances, monitor yourself for another 2 weeks, perhaps, see if you're seeing any changes in response to strategies that you implement on your own. But after that point, really considering reaching out to others for support and exploring psychotherapy as an option, I think makes good sense. But I think my big bottom line here is that it isn't necessary to wait until you're in a moment of crisis to reach out for that kind of support.
Okay, so don't wait until things are so bad that, as Marianne said, you can't get out of bed. So now there's different kinds of psychotherapy. Sorry, I'll let you address that point, and I'll come back to my question. You're good?
Oh, just very much.
I'm interested in that. Great. So I'm interested, there's different kinds of psychotherapy. I've heard of cognitive behavior therapy. There's other types. It's not always sort of lying on a couch with Sigmund Freud smoking a pipe, right? There's different approaches. Can you tell us a bit about the differences and how do you find the one that's right for you?
Yeah, and it's very true that there's a number of popular conceptions or perhaps misconceptions of what psychotherapy is, as popularized in TVs and movies. Cognitive behavioral therapy is the kind of psychotherapy that I provide. It's the kind of psychotherapy that I know the most about, but it is not the only psychotherapy that is available. There is all kinds of different interventions that are available and that have shown really strong promise. And in addition, there are also, as noted in the slide that was just shown, a number of virtual options as well. And very key these days, there's a number of online resources from self-directed types of videos and exercises like those found in sources like Bounce Back, as well as much more interactive and supported kinds of resources that are available, such as Beacon, as well as any number of apps and other kinds of resources that can be a support in addition to either virtual or in-person psychotherapy.
And I want to ask you that a lot of people can't afford the psychotherapy. So do these apps and things, do they help, or are they just delaying getting care?
Well, the evidence is still coming in. I do think that a lot of continued research needs to be done to determine, exactly who is best suited perhaps to these kinds of online resources. But the early evidence that we are seeing is quite promising. I've been excited to see it myself. Even Bounce Back, which, as I mentioned, is more self-directed. It's a lighter touch compared to some of the other kinds of resources that are available. You're seeing significant improvements in folks who are accessing that over the course of 6 months, which is a pretty long period of time. It's great to be able to see those kinds of gains. And similarly, you see strong evidence for internet-based CBT and others as well.
Right. And one last little thing before I bring in our next speaker, because of COVID-19, we can't get out, we can't see our doctors, we can't see our therapists. Does online therapy work just as well?
Does it work just as well? That's a hard question. You're asking someone who has a distinct bias. However, one thing I would note is that some work has been done, for example, within the substance use disorders, looking at exactly this question. And what they were able to find was that not only did they see comparable options across in-person versus online CBT over time, but that that similarity was seen even 6 months later. And you're seeing some of the same kinds of research being done in depression, some of the same kinds of promise, but I do think we need to see more data to really show that. But I certainly wouldn't describe online CBT or online kinds of supports as being just a temporary or a Band-Aid or an ineffective kind of solutions. I think for many people that may yield the exact same kinds of benefits as in person and is well worth considering.
Okay. And we have this grand experiment going on. We're going to learn how well it works by hook or by crook. Great.
Yes.
So let me bring in our fourth panelist, and then we'll come back and have some group questions. I want to ask Dr. Daniel Bloomberger to come in and join us and tell us a little bit about yourself and your work.
Hi, Andre. Thank you. So I'm a psychiatrist and actually a geriatric psychiatrist by training. I'm also a researcher, and my research throughout my career is focused on the use of brain stimulation therapies. And at CAMH, at the Center for Addiction and Mental Health, I run the Temerty Center for Therapeutic Brain Intervention, which delivers brain stimulation therapies across the spectrum of these treatments. And I've been involved in treating depression, from youth with depression to women experiencing depression during pregnancy, to adults, to older adults with depression. So my work is focused on innovating brain stimulation treatments across the lifespan.
Okay. Now, brain stimulation has some really negative connotations and some really positive ones. Tell us a bit about, the classic, if I come back to the movies again, is ECT, electroconvulsive therapy. Is that a evil thing like we see in the movies, or is it an effective treatment?
Well, so ECT, electroconvulsive therapy, many people's images of ECT still date back to One Flew Over the Cuckoo's Nest, and it's the image that people have. But the reason it's still around is it's the most effective treatment for depression and severe depression that exists. Even with all the innovations, it still is the most effective treatment. And actually saves lives, and is a very effective treatment when people have thoughts about taking their own life and when depression is very severe. So it's a very important treatment. The problem with electroconvulsive therapy is that it has some costs, and those costs generally involve some memory impairment. From a medical standpoint, it's probably the safest medical procedure that exists in medicine. The risk of something bad happening medically is no greater than having the general anesthetic that's involved during the procedure. But the memory impairment is variable when people experience the treatment. Some people have very little, and some people have some memory impairment that really affects their functioning. Over time, ECT has evolved quite a bit, and we've figured out ways to deliver the treatment that cause much less memory impairment than it did 10, even 15, 20 years ago.
But I've written about patients who've had ECT, and it's a miracle for them. There are people who are profoundly suicidal, nothing works, and then bang, this electric stimulation does magic.
It really is. It's almost like an awakening treatment for some people, and that's how I, in some respects, got involved in this work, seeing some patients with extremely severe depression, not really able to speak, eat, or drink, and after several treatments, come back to their normal selves. So it is a life-saving procedure.
Now, there's other more modern ones using magnets, things like rtms. I know I've gone in and I wrote about this, and they ran a magnet over my head. It didn't help me, but this can help people when it's used as a real treatment.
Right. So that's a technology called transcranial magnetic stimulation. And so transcranial magnetic stimulation is a way to non-invasively stimulate the brain using a magnetic field. And it involves using a magnetic coil just like this, and it goes over the head, and it can stimulate the areas of the brain that are involved in emotion and thinking. And it's actually been around since the early 90s, and there's quite a considerable amount of evidence supporting its use for the treatment of depression, and it's widely available in
Okay, I think we've lost Dr. Bloomberger there for a moment. We'll hope that he gets reconnected. Maybe it's an electrical issue when he put that magnet on his head. I'm not sure. But maybe we'll come back. So I had a question that right away when Dr. Kennedy started speaking, so I'll jump right to that if I could bring Dr. Kennedy back. And they're asking, is it true that antidepressants lose their effectiveness over time? So this issue of, did they keep working? Do we have to keep changing treatments? If we can get Dr. Kennedy back, I'll see if you can tackle that one.
Sure, I think that's a very fair question. I think that this became a common question with the serotonin reuptake inhibitors, the Prozac era, if you like, which began in the late 80s. People after some people would have said, this is the best I've ever felt. And they were in treatment, they were closely followed. Maybe 2 years later, they were not being seen very often. It's hard to know in some cases whether there was actually people didn't fill their prescriptions, there wasn't the same connection, and so the so-called loss of efficacy or effectiveness was not just simply a drug effect wearing off. But I've certainly seen people who are convinced that they have been taking the treatment regularly and they feel the effect has not been as good. So sometimes we do have to either add an adjunctive treatment, a booster, if you like, to help the first treatment, or we switch to a drug that maybe does something more. The serotonin drugs really were a game changer, mostly because they had less side effects than the other older drugs from the 1950s on. But for example, we then had drugs that add impact in terms of the norepinephrine or noradrenaline system. So that might, for some people, increase their energy, their activity. And so they, for example, you may switch somebody from Prozac type drugs to one of these others to see if you get the effect again. But I think the short answer is it seems to happen for some people, but it may be there may be other variables as well as the effect on the drug itself.
Great. So I think we've got Daniel back, so I'm going to bring him back on the screen, and we'll get back to talking about electrical stimulation of various sorts. I'm interested, Daniel, in how do people get access to these? You know, you can get antidepressants by going to your family doctor, but how do you get ECT? How do you get rtms, these more modern treatments?
Yeah, so the simplest way, so rtms, I think, as I was saying before, is not covered yet in Ontario. It's covered in other provinces and in other places in the world. Hopefully at some point, it will be a treatment that's available more broadly in Ontario. But right now, the way to access these treatments is to get a referral to a clinic that does these specialized treatments. At the Center for Addiction and Mental Health, we've been doing these treatments since 2002. And in the state of rtms for depression is that we're looking at refining and improving the treatment. It's an effective evidence-based treatment that works when antidepressants or psychotherapy doesn't work. And we're looking at making it even better by using tools of modern neuroscience to figure out the right patients that are good candidates to respond to this treatment, and to potentially optimize it by increasing the dose of magnetic stimulation. ECT is available in most general hospitals in Ontario. It's also, we have the largest ECT clinic here at CAMH as well.
And same question I'll ask you that I asked about psychotherapy. How do you know when you need these treatments? Are they only for people who are very suicidal? At what point do you get this type of treatment rather than psychotherapy or drugs?
Right. I think rtms is a very useful treatment earlier in the course of someone experiencing depression and not responding to either psychotherapy or medication treatment. It's a very good treatment if people have not responded to one or two different treatment options. That's probably where it's best used. ECT, because it involves anesthesia and is very involved treatment and the risks of memory impairment, in general, people decide to pursue ECT when their depression is very, very severe.
Great. So we'll bring all the panel on, and I'm going to try and work through a whole bunch of questions posted. So I'm going to put you all on the spot very quickly when I look at the various questions coming in. So I think I'll start with you, Marianne, because there's a question, and it's someone saying, you know, I'm a student, I can't afford therapy, I'm a bit scared of drugs. What should I do? What do you recommend as someone who's been in that position?
Well, talking to your family doctor first. If you don't have a family doctor, simply going to a clinic and talking to a general practitioner is an excellent way to just start to figure out what you might need. When it comes to things like psychotherapy and stuff, there are free options, counseling options. Most schools offer them, and community services also offer them. You might have to do a little bit of Googling, but there are places you can get free stuff. And as for being scared of meds, it's not scary. It's something you try, and if it works, it's amazing. And if it doesn't work, so what? You try something else. And I've had to try several meds for several different things, sleep medication, anti-anxiety, all of that kind of stuff. And for the most part, it's really just, oh, okay, this didn't work. I'm in the exact same place where I was before, or this worked and I feel great now. So when it comes to things like side effects, most side effects these days of the medication that you would be started on, at least, are very minimal and infrequent, if I will.
Okay. So we have a couple of questions with people asking about treatments, and specifically what are non-pharmacological treatments for people with not just depression, but also other conditions. So developmental disabilities, dementia, that makes it more complicated maybe to take meds. I don't know who's going to want to tackle that tough question. Maybe Lina, can you think of that? People with developmental disabilities, for example, how do you treat depression in them without meds?
Well, I think there's different kinds of options that are available that do not require medications, although certainly options that are relevant to dementia, I might ask Daniel to chime in on. There are a number of behavioral kinds of interventions that have shown promise, and many of the kinds of interventions that you might already have some familiarity with, things like even mindfulness or behavioral activation, they don't require a lot of verbal work. They don't necessarily all require writing out lengthy thought records and all of the different kinds of exercises and skills building that are often associated with psychotherapy, such as cognitive behavioral therapy. And so there are these different kinds of accessible options, I think, that may be more suitable to a broad range who have different kinds of accessibility concerns and issues to navigate. I'm not sure if that would speak to or exactly what the nature of the evidence base is for those with dementia for those types of psychotherapies. Excuse my cat. But that's where I would start.
Okay. Well, maybe we'll ask Daniel. I know, Daniel, you have some expertise in dementia. How do you treat depression in someone with dementia?
So, treating depression in someone who has dementia is not all that different than treating someone who just has depression. Treating depression in late life is an extremely important thing to do, because we know that depression is one of the major risk factors for developing dementia later in life. So treating the depression aggressively is a very important aspect of potentially preventing dementia. And interestingly, older adults respond very well to brain stimulation treatments, including rtms, when they experience depression. Our data suggests that up to a third of people will experience a remission of their depression with a treatment like rtms. And there are other types of brain stimulation treatments that are being combined with cognitive training to also potentially prevent dementia. So that's a treatment, neurostimulation modality called transcranial direct current stimulation, which sort of primes the brain to be more receptive to behavioral interventions. So, neurostimulation is becoming an aspect and component of all types of interventions to treat depression and potentially prevent dementia as well.
And the question, while we're talking about rtms, people are wondering, how does this work? Why magnets? Do you have metal in your head or something? People are trying to, can you explain simply how it works?
So I'm sorry, I got cut off when I was explaining it, but so RTMS and TMS involves the principle of electromagnetic induction, which is the principle that a magnetic field can induce an electrical current in a conducting tissue or substance. So we know that our body conducts electricity, our heart pumps on electrical signals, our brain communicates on electrical signals, and our brains can experience an electrical current. So the magnetic field actually causes brain cells to fire, and we change the brain cell firing in areas of the brain that are involved in emotions and thinking and processing of information. So by specifically targeting the areas of the brain involved in emotion regulation, we can potentially treat the depression. That's the principle of how RTMS works.
Oh, it's neat. Sydney, a couple of questions. People are very interested in ketamine. Why aren't we talking about ketamine? Can you tell us a little bit about that, why it's so popular, and does it work?
Well, we do have a slide actually that we passed over, but I think it's interesting that we are moving beyond the serotonin type drugs. And ketamine is an anesthetic that's been around for since the 50s or 60s. But about 20 years ago, it was recognized that if you give it intravenously, people with depression who had failed to respond to just about any other treatment, even within hours, began to feel better. The issue was that it was an intravenous, it was an infusion. That's not actually the slide, but that's a good overview of the different things that we've talked about today. The ketamine slide would highlight the fact that we have seen that this drug has been adopted, if you like, as an antidepressant, working through other systems rather than serotonin, for example, glutamate. We don't know if you get 4 or 6 intravenous infusions, how many people will remain well. I suppose in some ways it's a bit like a course of ECT. We are doing a study actually where we're looking at ketamine compared to ECT and looking at over 6 months how well people will do. And if they don't do well with one, they can switch over to the other treatment. But following on from intravenous ketamine, one of the major pharmaceutical companies took a part of ketamine, which would be called S-ketamine, and they put it through all the rigorous trials that would be necessary to get Health Canada FDA approval. And so this treatment called S-ketamine or Spravato is actually now available as an intranasal treatment. So it obviously is less invasive than having to do an IV infusion 2 or 3 times a week. Again, it also seemed to help with reducing suicidal ideation. So there's a real plus there. There's a third line of work that has been emerging, which I think is very interesting, and that is, if you like, a rapprochement between psychotherapy and some of the novel therapies. So we have low-dose ketamine being used with psychotherapy in ketamine-assisted psychotherapy. We have psychedelic agents, which were essentially banned in the late 60s, are being carefully evaluated under scientific conditions and show in low doses tremendous promise in the treatment of depression. And so we have psilocybin, the magic mushrooms. We have other psychedelic agents being tested with psychotherapy. So this is a real hot area, I would say, in terms of the novel treatments for depression.
So we've covered ketamine, we've talked about psychedelics. We have to have a quick word on cannabis. Cannabis help with depression? Does it hinder? I know that's not an easy question to have to answer briefly, but maybe you could give it a shot, Sydney.
Not everybody will necessarily agree with me, but I've been part of a network called the Canadian Network for Mood and Anxiety Treatments, or CanMet, and we actually have a review in press where we looked at that very question: does cannabis help depression or not? And based on the evidence, there are some studies where people coming off cannabis actually showed an improvement in ratings for depression. The trials have not been carefully done the way we would expect for more rigorous assessment, but the evidence is more, for example, for CBD to potentially help anxiety and maybe pain in some cases. Some people use it for difficulty with sleep. But the actual antidepressant effects of cannabis, in my opinion, have not yet been shown in significant trials.
Great. So I have a couple of questions. People are worried obviously about the cost of treatment. Medicare doesn't necessarily cover our drugs. It doesn't cover therapy. So maybe, Lina, someone's asking, I don't have private insurance. I don't have a lot of money. Where do I start? I can't afford my antidepressants. I can't afford to go to therapy every week. What do I do?
Mm-hmm. And it's an excellent question, and it's a real barrier for many. Now, I think beginning with your family doctor is a great initial step, and sharing what your barriers are in terms of costs and travel and other relevant restrictions. But really, I think there are a number of options that are available that are either free or with sliding scale costs. For example, receiving psychotherapy within the context of a hospital like CAMH is covered by OHIP. So there are certain healthcare facilities like hospitals like CAMH where these kinds of resources can be accessed in a way that's covered by our provincial insurance. Similarly, there's any number of university training clinics, for example, as well as other clinics that do offer sliding scale and in some cases free services for those who are unable to pay or to cover those kinds of costs. Similarly, there's many different kinds of peer support agencies and peer support services that also have limited, if any, fees associated with them. And all of these are remarkable, caring clinicians. They're excellent places to receive services. So it's not receiving compromised care by going to one of these kinds of options.
Great. So we only have a couple of minutes left. I always like to end panels on a positive note. So I want each of you to send us home with what gives you hope for treatment of depression getting better, people getting the care they need. Maybe I'll start with you, Daniel. What gives you hope going forward about improvements in treatment and care?
So I'm tremendously optimistic about, I think people have seen what a treatment like transcranial magnetic stimulation can do. And that's why it's available in so many places. So I'm optimistic that it'll be something that'll be more widely available to Ontario, to people in Ontario sooner. And I do also think that we are coming closer to being able to personalize treatments with a treatment like rtms. We're understanding the brain circuitry better, and we will be able to target the underlying personal brain circuit dysfunction with a treatment like rtms. And I think we'll be able to get more people better in this personalized way.
Sydney, going forward, what gives you hope?
Well, since you mentioned hope, I would like to highlight what used to be known as the Mood Disorder Association of Ontario, now known as Hope and Me, who have done a lot of work in supporting individuals with depression, with bipolar disorder, providing group support, not necessarily therapy, but also having resources. And that group worked with our network, and I believe Marianne is part of the same community advisory group, to translate the kind of technical details of the treatments that we've talked about tonight, but into everyday language so that persons with lived experience, their families, their friends, can go and have good conversations with healthcare providers about the kind of treatment that might be best for them. So that, I think, is the hope part. And the other part is, to echo Daniel, I think we actually, with some of the measures, and I showed you the concept of looking at different circuits in the brain, I think we can also understand that there are some ways of understanding genetics, and even how genetic changes with environmental stresses can come out in blood samples. So there are ways that we can move forward to try and identify targeted treatments, similar to, for example, some of the breakthroughs with specific drug treatments for different cancers. We haven't got anywhere near there in depression, but I think those are the kind of things that would give me hope in the long run.
Good. Sounds like lots in the pipeline. Lina, what gives you hope looking forward?
Well, I think where my hope comes from is twofold. Certainly, I'm seeing meaningful and increasing investments in both clinical research and clinical services. We're seeing, as you've seen here, innovative treatments, novel treatment combinations, all of these approaches really being rigorously evaluated and investigated, as well as substantial investment in implementing the services that we know already work for folks into our health system and to the people who need it. So that's huge, and I see it as something that's growing over time. And the other thing that I'm seeing happen at the same time is partnerships and awareness and really growing acknowledgement and decrease in the stigma associated in reaching out for those services. And increasingly, I'm hearing from folks that not only do they see that it wasn't too late for them to reach out for help, but nor was it too soon, and that there was always something that they could be learning about their health and about the kinds of resources that were available to them on their journey. So I've really been inspired by that, about how many people are coming together to address this issue.
Okay, so Marianne, I want to give you the final word, because you're sitting here, you're looking like the picture of hope. Someone who's been treated, who's thriving. What does our future math teacher, what gives you hope?
Well, I think the view of depression is definitely changing. And with increases in research, we are not where we should be yet. But there are so many different types of treatment available now. And everybody's depression is different, so everybody's treatment will be different. And it might take some time to find that treatment that works for you. But the fact that there's so many different ones available means that there's more chance that you will find something that works. So I guess message-wise, don't give up. There's always going to be something that will work. You just have to find it.
Wonderful, wonderful, hopeful note to end on. So I want to thank our panelists on behalf of Ontario Brain, and Marianne Lewis, Dr. Sidney Kennedy, Dr. Lina Quilty, Dr. Daniel Bloomberger. Thank you for your insight, for taking the time with us tonight. Thank you to the audience, a great big audience who's tuned in tonight. We're going to post, before we leave, a slide with resources, some things where you can look up online to get some help with depression. And again, thank you to everyone for tuning in, and thank you for this really important discussion, and have a good evening and stay well during this pandemic.